So I would like to request your cooperation, sir, for our quality assurance process. It is imperative that the framing of doctors' videos meets our quality standards. Therefore, I kindly request you to maintain a stable position and ensure proper camera framing throughout the entire session.
Okay.
Additionally, please
Yeah.
refrain from engaging in any other activities while the recording is live. Furthermore, in the event of low network bandwidth, I recommend sharing your presentation from your laptop, and for verbal communication, kindly join the session using your mobile phone. Your adherence to these guidelines will greatly contribute to the overall quality and effectiveness of the recording. Thank you for your understanding and cooperation, sir. We'll be going live in a moment. Greetings and a warm welcome to everyone. I am Asya, the assigned moderator from Clarnet. It is my pleasure to extend a heartfelt welcome to all the delegates joining us from across the country. We are indeed fortunate and delighted to have the valuable support of esteemed doctors, and I express my gratitude to each one of you for dedicating your time to be with us today. Allow me a moment to introduce our platform Clarnet to you all. It proudly stands as one of the largest live digital continuing medical education platforms in India, providing a space for doctors to create and share medical content. Now, I would like to extend a special welcome to today's distinguished speaker, Dr. Aman Setiya sir, holding the degrees of MBBS, MD General Medicine. He is working as the assistant professor at Venkateshwar Institute of Medical Sciences. He is also the consultant faculty at AFMG, DBMCI, Medway director and founder, Sehat Multispeciality Polyclinic, CR Park, Delhi. The topic of today's session is diabetes treatment goals for older adults. I would like to give you an overview of today's topic before we start the session. Older adults with diabetes demonstrate unique challenges and warrant considerations not traditionally associated with managing diabetes. Older adults with diabetes are more predisposed to develop acute and chronic microvascular and macrovascular complications associated with diabetes, including major lower extremity amputations, myocardial infarctions, visual impairments, and end stage renal disease compared to any other age group. The health of the patient, presence of comorbidities, cognitive and physical status, the risk for hypoglycemia, and life expectancy should guide glycemic goal settings. Lifestyle modifications are crucial for all patients with diabetes, including older adults. Pharmacological interventions should be considered when lifestyle modifications alone do not suffice to meet target treatment goals. So, without any further delay, I would like to hand over the session to Dr. Aman Setiya, sir. Kindly proceed with your talk, sir. Over to you.
Okay, so my screen is visible.
Yes, sir, your screen is visible.
Okay, so my name is Dr. Aman Setiya. So here I'll address a few topics like diabetes treatment goals for older adults. So basically, the topic is like a little different when we try to manage diabetes in younger adult versus older adult. So here I just want to highlight those important points. So starting with the very first thing, what should be the approach towards a patient who is old? So the meaning of word old here is like either a person who is above 50 or a person who is having some sort of cardiovascular or renal comorbidity. So first approach towards patient is like we should take a proper history. We should do a proper physical examination. Then classification of diabetes is individualized approach. Means there are some many new forms of diabetes which we should know. Like sometimes we have ketosis prone diabetes, we have MODI, we have LADA. So MODI generally we see in young people, but even like I can see in many old people, type 1 diabetes also diagnosed late, although it's also disease of young. Then a proper lab assessment is needed. Now, what are overall goals in elderly? Understand, in elderly patient, they have more chance of hypoglycemia. They have more risk of diabetic micro as well as microvascular complication. So first goal is we should eliminate symptom related to hyperglycemia. So what I mean by symptoms related to hyperglycemia means there are some sort of acute symptoms or there are some chronic complications. So all these symptoms should be eliminated. Then we should reduce or eliminate long-term micro and macrovascular complication, and allow the patient to achieve a normal lifestyle. So these are overall goals in a patient. Now, previously we were having different terms. Like, so there was a term called intensive insulin therapy. Then this term was replaced by intensive glycemic control, tight control. Now we have a common term. These three terms, these are obsolete now. So instead of this, now we have a term called comprehensive diabetes care. So based on this CDC, comprehensive diabetes care, we have certain guidelines that we should follow in order to manage a patient with type 2 diabetes. So what are these guidelines? Understand this thing. The first thing is glycemic goal, or I can say target HbA1c, or target fasting blood glucose, or target postprandial. That is individualized. Individualized means in older adult we should not make a target of like HbA1c less than 7. It can be less than 8. That's also fine. The second guideline that is important is SBGM. SBGM stands for self blood glucose monitoring. So all the patients should be educated to monitor their blood glucose on their own. So this is like relatively like a painful thing, like we have to prick ourselves daily. So nowadays this is replaced by continuous glucose monitoring, CGM. So this is like a very handy device placed on your arm, and that can monitor, and even not that expensive nowadays, costs around 6,000 rupees. Third, there should be HbA1c testing. HbA1c testing should be at least like 3 to 4 times in a year in older adult. Compare, you can do this like 1 to 2 times in younger person. So HbA1c testing should be done 3 to 4 times in a year. Then the very very important aspect is lifestyle management. So this will have many component like medical nutrition therapy. Your diet should be less than 1600 kilocalories per day. We should avoid high carb meals. Then try to detect, prevent, and manage complication. And we have to treat diabetes and other diabetes relevant conditions. So these are CDC guidelines. So moving to a type 2 diabetes management, you can see I told you like glycemic control should be individualized. So every patient is different. Every patient has different comorbidities. So first step is diet and lifestyle modification. That is, I told you less than 1600 kilocalories in a day. Then we have exercise. So it is nothing, just 20 to 30 minutes daily. On an average, we can say 150 minutes per week of cardiac exercise. Then the add-on thing is medication. The second point which I should add is like treatment of not only diabetes but also associated condition. Like this is important. Like if you are suppose you are having a young person with type 2 diabetes, and patient is having metabolic syndrome or dyslipidemia, and you are not giving statins, or you are not giving lipid lowering drugs, so that person is manageable. But in old people we have to control dyslipidemia. That's very very important. We have to control hypertension. We have to control obesity. So if you try to control these three things, understand this thing, we can reduce the complication by 50%. That's very very important. Then all the patients should be screened for complication like retinopathy, nephropathy, neuropathy, cardiovascular, some other complication like dermopathy, some autonomic neuropathies. All these complications should be screened. Now understand, the very very important thing is goals are different in adult and older adult. So I told you before, for a normal adult, the target HbA1c is less than 7%. But in older adult, if it is coming in the range of 7 to 8, that is also acceptable. So that is first thing, which is the highlight point of this meeting, this seminar. That is, in older adult, target HbA1c is not less than 7%, it is less than 8%. So if you are having a patient and who is having an HbA1c, like previously it was 10.5 or 11, now it is 7.5 or 8, that is means patient is doing good. So that is very, very important. Similarly, we have a target of pre-prendial in the range of 80 to 130 milligram per deciliter, and post-prendial in the range of 90 to 140. So first important thing is treatment of diabetes is different in younger adult versus older adult. Moving to a term that we have, diabetes self-management education and support, dismiss. So here we have three things. So diabetes patient should be educated for self blood glucose monitoring. Then patient should be educated about continuous glucose monitoring. That is called CGM. So this is like a very handy device. So I am using this in my practice, and many elderly patients they can continuously monitor. Sometimes like it happens, some patient they get a fear like their blood glucose is constantly high, but in after 2 3 days you will realize the value of this thing, like your sugar is controlled or not. Then, if sometime you get some older adults, sometime for type 1 diabetes, in that case, one more thing is important, that is urine for ketones. So, self blood glucose monitoring one, continuous glucose monitoring two, and urine for ketone is an important test that is important in type 1 diabetes, because type 1 diabetes they are more prone to develop decay. Now, advancing to this, like the first and the most important thing, like you will see many patients, you have tried one OHA, two OHA, three OHA, still there is no sugar control. So, because they are not taking a proper control over their diet. So, the term that we have is called MNT. MNT stands for Medical Nutrition Therapy. Medical nutrition therapy means, understand this thing. The first and the most important in diabetes is not drug, it is your lifestyle management. But we have certain challenges here. The first challenge is patient those who are having diabetes. Those patients who are having diabetes understand. Sometimes like they will tell you like I am consuming food outside. My lunch is almost outside. I'm eating in a restaurant, or I order food from Zomato, Swiggy, or restaurants. That is like they don't take care of their proper meal schedule. Some patient they will say they skip breakfast, they skip. Then in India you can see there are many people like they are doing intermittent fasting for weight loss, which could be a dangerous thing in type 2 diabetes in elderly, because there is more chance of hypoglycemia, and in older patient because of having neuropathies, some other diseases, they sometimes may not recognize the symptoms of hypoglycemia. Then if you see like even like our relatives they are having fasting, like Tuesday fasting, or I can say Navaratri fasting. Then we have different festivals for fasting. So these Ramadan, religious fasting, intermittent fasting, these are recommended, but these should be done under supervision of a physician. So that is second challenge. Now coming to physical activity, so understand this thing. Diabetes patient they are advised to do 20 to 30 minutes of cardiac activity daily, or we can call this 150 minutes in a week. So it could be like a moderate, mild to moderate cardiac activity like walking or jogging. So that is advisable. Cycling. They can also try swimming. The third component in type 2 diabetes in order is important is psychosocial care. The reason is if you see, whenever you are diagnosed with diabetes, now you are having a new journey. Now you will feel like you will take OHA for lifelong. Your life will change. You will not eat sweet. You will not eat the food which you like. You will not eat biryani. You will not eat other food things. So that is something. So diabetes patient they are more prone to develop, I can say, secondary depression. This is very very important. Depression is very common in diabetes. Then one more thing which I have noticed in my practice, like many old people, like if you see like our grandparents they are having, so they are not eating sweets or sugar or tasty food from past few days. Now whenever they get an opportunity they will do binge eating. So that is like if you see bulimia like diseases, binge eating disorders, they are also commonly seen. Means they are not eating, I can say, food with high glycemic index, or they are not eating tasty food for few days. Then once, whenever they get an opportunity, they will eat sweet. Like sweets are very famous in India. People consume sweets for festivals, for occasions. So that is something like depression and binge eating disorders are also common in older adult. So now I'll explain two cases. These are like our patients which are coming in our OPD. First is like a 35-year-old young person. So this is like a case which I'll explain. Like this patient was diagnosed with dengue. Platelet count was 1 lakh. No other comorbidity except patient was obese. Patient was obese with metabolic syndrome. Like patient was having diabetes, not taking any drugs. Patient was having hypertension, patient was obese, patient was having dyslipidemia, means triglyceride was above 150 and HDL was less than 40. So this patient was having dengue. All other reports came normal, but his platelet count was not increasing. It was 1 lakh. So we started only IV fluid. So single donor platelet or RDP was not recommended. But the healing process in normal people, it take mostly like 3 to 5 days. You can see platelet count will increase. Patient will recover from dengue. But this patient took nearly 10 days. The reason is he was having diabetes. HbA1c value was 7.2 and patient is not taking any OHA. So understand this thing. Even you are young, wound healing is delayed in diabetes. And this is something which is like a practical example which I'm telling you. Now coming to case 2, a 50-year-old with HbA1c value of 6.4. So usually we label a diagnosis of diabetes after HbA1c value more than 6.5. So this person was obese. So like now this patient is 50-year-old, HbA1c value is 4.5. The reason is patient is taking a proper diet. He have taken proper diet means he is taking less than 1600 kilocalories in a day. Major source he is taking, like he's dividing this into carbohydrate, protein, fat. He is taking an adequate number of protein. That's very, very important. Low carbs, he's avoiding food with high glycemic index. Then he's not taking any sort of trans fat. So now understand this thing. The point is, in a span of 2 years, this was a patient which we call pre-diabetes, or we call this insulin resistance, or pre-diabetes, or impaired glucose tolerance. We have different terms for this because diabetes label. But again, is it possible to retard the pre-diabetic state, or I can say impaired glucose tolerance to normal? Answer is yes. After being regular in exercise and diet for 2 years, right now the status of this patient is 50-year-old, lean muscle mass, a decent body, non-obese. Weight previously weight was 90 kg, now it is 62. So that is very, very important thing. When you are reducing weight, you will also reduce the complication. Now understand. So I told you like in type 2 diabetes, glycemic goal should be individualized. So a person who is having no comorbidities in that target is different, and a patient who is having some comorbidities like renal impairment, or I can say CKD, acute kidney injury, or heart failure, or any other complication, that goal is different. For older adult, target is slightly on a higher side. That is, it is HbA1c. Target should be less than 8, not less than 7. Then we have medical nutrition therapy. I told you MNT. Then increase physical activity. Weight loss is recommended. Then we can start with one drug, that is metformin. It is like the reason is it is not causing hypoglycemia. This is the drug which we start first. But again, this drug is having a certain plus point, certain minus point. So plus point of metformin is like it will not cause hypoglycemia. It is inexpensive. So means you can, it is the cheapest OHA in the market. It's having a good control over HbA1c. You can see like 1 to 2% reduction over a few months. Then this drug, understand metformin is a drug which can also reduce micro and macrovascular complication in long term. Then we reassess the patient's HbA1c. Then we add metformin plus second agent. Now here is the trick. The second agent in youngsters, in youth, in young adult, we prefer to add will be sulfonylureas. But what our latest guideline recommend in older adult, it's better to add either an SGLT2 inhibitor, SGLT2 inhibitor. So these are drugs like canagliflozin, dapagliflozin, empagliflozin, or we should add a GLP analog. But GLP analog, most of them are subcutaneous except semaglutide, which is oral available GLP analog. So in that case, what is the option? We can add a DPP4 inhibitor, that is your gliptins, sitagliptin, vildagliptin, linagliptin. So my point is start with metformin, add sulfonylureas in young adult, add SGLT2 inhibitor, or we can add gliptins in older adult. Then we can combine this therapy, or we can add two more drugs. So total is like three drugs. If it is still not controlled, then we should add insulin. Even many physician, what they are doing nowadays, they are even replacing metformin with SGLT2 inhibitor, because two diabetes patient ultimately they will develop complication like I can say complication of diabetes, which are CKD, heart failure. These two complications can be prevented by SGLT2 inhibitor. So that is the game changing drug. So to conclude this, I'll say what is critical in older adult is more chance of hypoglycemia. So older people, they have, I can say something called hypoglycemic unawareness. So they will not feel the typical symptom of hypoglycemia, and they are prone to develop hypoglycemia. So we should always educate them about all the symptoms. And remember, this hypoglycemia is something that's very common in old people compared to young adults. Second is which OHS, while like I told you in our practice, what we recommend start with metformin, add SGLT2 inhibitor, or we can add gliptins, or we can also consider other drugs. But remember, OHS should be considered based on their side effect. For example, a person who is having liver cirrhosis, a chronic alcoholic, avoid sulfonylureas. A person who is having a chronic constipation or diarrhea, or I can say inflammatory bowel diseases, in that case, we should avoid acarbose, obligose, or drugs which are like alpha glucosidase inhibitors. Then I can say a person who is having type 2 diabetes, old person, and the person who is having, I can say, more chance of hypoglycemia. He is admitted 2 or 3 times in the IPD because of hypoglycemic episode. We should avoid sulfonylureas. A person who is like having a chronic B12 deficiency, so in that case, or a person who's having an EGFR of less than 30, we should avoid metformin. Any form of acidosis, even it is ketoacidosis or lactic acidosis, we should avoid metformin. So OHA should be decided based on their side effect. Like now coming to GLP analogs, and which we call them incretins, and coming to some drugs like we have DB4 inhibitor gliptins. So remember, these drugs are also modified in their dose whenever a person is having CKD or a deranged LFD. In that case, what we can consider, understand, linagliptin is one of the safe drug which we can use in a patient with deranged kidney function. Now, understand this thing. SGLT2 inhibitors, although they can cause Fournier's gangrene, although they can cause UTI, candidiasis, they can cause cystitis, they can cause, I can say, auto amputation, they can cause euglycemic ketoacidosis. So these are 5 common side effects of gliflozins or SGLT2 inhibitors. But on long term, understand, they have benefits. So their benefits are surpassing their side effects. Benefits means they are the drugs which can prevent mortality. They are the drugs which prevent mortality. They are the drugs which prevent CKD. They are the drugs which prevent heart failure. So these are three major cause of death in diabetes. So if you see the major cause of death in diabetes, there are two major cause of death. One is diabetes patient, they usually die because of heart failure or kidney failure. And both these complications are prevented by adding gliflozin. Then remember, hypertension and dyslipidemia, if you are not treating this in normal population, that is fine. But remember, blood pressure of more than 130 by 90 should be treated in diabetes. Dyslipidemia should always be treated in diabetes. So that's very, very important. Dyslipidemia, you can start statin, or we can add omega-3 fatty acids. So these are the things. Hypertension and dyslipidemia should be controlled. So why this is important? Understand, when you control diabetes and you are not controlling blood pressure and lipid, then remember, the chance of microvascular complication will not be reduced. So if we control all three, we will reduce the complication by we will reduce the complication risk by more than 80%. So these are three things which are very, very critical. Now, what's changing the game? Like I told you, in practice, in older adult, two things are changing the game. One is SGLT2 inhibitors because of their surplus benefit, because of their decrease in mortality. Second thing is GLP analog. The reason, only problem with these two drugs are they are a bit expensive. So many people are not affording this. But remember, if in practice, if somebody is willing to give a medication, then remember, These are the drugs which can increase your patient life by 10 to 20 years. That's very, very important. So this is like about my discussion of diabetes management in older adults. Your questions are welcome. Thank you so much. Over to Asya.
Thank you so much, sir, for your wonderful deliberation and informative content. Yes, sir, we have received a few questions from our participating doctors. So, may I have your permission to present them, sir?
Yeah, sure.
Okay, sir. Please allow me to share my screen.
Yeah, sure. Okay, so I'm answering this first question. How does physical activity factor into your approach to setting treatment goals for adults with diabetes, considering their mobility and functional limitation? Okay, so this is like a very good question. So understand this thing. Like there are many older adult, though in those who don't have any mobility issue and functional disability, then we should advise. But there are many different sort of activity other than running or jogging, or there are some I can say, suppose a person who cannot run, or who cannot who's having some cardiac failure or NYHA grade 3 or 4, then mild to moderate activity, at least walking is allowed, right? Or hand movement or a little movement, some physiotherapy exercise are advised. So like we advise the patient with some physiotherapeutic exercises, right? Or some other things other than running, jogging, that is advice. But some movement is important in diabetes. Active or passive, both are considered cardiac activity. Moving to next. How do you involve family members or caregivers in discussion about diabetes treatment goals for older adults, and what role do they play in supporting treatment management? So understand this thing. So most time you will see like patient will come with their children, with their son or daughter. In that case, first thing is we should explain these like these are now older adults. So there should be always a person taking care of them. Like I'll tell you my example. Like my mother is not diabetic, but my mother's father, means my grandfather, he is diabetic, and sometime he's been means he's not telling anyone but eating sweets. And my even mother is encouraging, like at least once in a month he's eating, let him eat. So this is something which you should not do. So family members should be counseled. So I counsel my mother first, like it is not good for him because his HbA1c is not controlled, because secretly he is eating sweet. So first we should explain, like once he was admitted, and this admission took him like 10 days in ICU. So he was saved. But then my mother understood. So we should encourage our caregivers, like these are old people, in them healing is delayed. So we should always restrict their sugar intake. I mean, restrict means we should not allow them to take sugar, because all these high carb means sugar, they are affecting their kidney. Second is like what I advise family member, if they can afford, so they should always consider applying CGM, continuous glucose monitoring. And even I can see like out of 10, 5 patients, they patients caregiver, they are buying their parents a continuous glucose monitoring. That is giving them a real status. Moving to next.
Thank you so much, sir. We do not have any more questions. And thank you so much for explaining all the inquiries for from our participating doctors so well. So, sir, thank you so much. Any concluding remarks that you want to give for the session, sir?
Just I will say like there are a lot of patients with diabetes. The most important thing in managing type 2 diabetes in older adult is diet and exercise. That is first, then we have drugs. So we should understand this thing like diet is very, very important. We call this medical nutrition therapy and mild to moderate exercise. That is what we advise to patient. That come first, then comes drug.
Okay, sir. Thank you so much, sir. We would be glad to conduct a session with you again on our platform in the near future.
Thank you, ma'am.
And I extend my gratitude to all the participating doctors for your consistent engagement on our platform. And lastly, before ending the live, I would like to request you all to follow us on our Facebook, LinkedIn, Twitter, and Instagram pages to stay updated on the latest medical information. So, with everyone's approval, can we bring this session to a conclusion, sir? Okay, thank you so much, sir. Have a great day ahead.
Okay, thank you, ma'am.